Thank you, everyone. My name is Kavita Patel. Thank you for that first panel that teed off a lot of what we're going to get to in our second panel, which is understanding the pricing process and spending consequences for breakthrough therapies. I just want to keep a couple of kind of points that some of the previous panelists raised, and I think, again, it's probably pretty important. I'm still a practicing clinician. I actually had a 32-year-old woman with Hep C, newly diagnosed, kind of a similar story to Dr. Dietrich's, and her first question to me was whether her insurance company would pay for any of this. And I said, I don't know what this is, and I don't know if I can promise you anything right now. So I think that Margaret's point about where patients are and kind of where their interests are, as well as the intersection with the headlines that we've been reading, raises this issue around hepatitis C. But if it would, most of my work is in other chronic diseases like cancer and coronary artery disease and diabetes. As Dana mentioned, if we actually had something for the 25 million plus patients that have diabetes, we would also be having this exact same conversation, if not at a much higher magnitude, when we talk about 3.5 million patients with hepatitis C. And as Dr. Dietrich pointed out, that's an underestimate. That's partly why we're having this conversation. It's not just that one drug that costs approximately $84,000 by sticker price is the issue. It's many drugs for a large population for which we have, while Dana presented modeling which illustrates kind of both short and long-term effects, many of the insurers, patients, and providers are really dealing with kind of short-term effects, and that can be very complicated. It's also a much more complicated issue when we introduce this concept of kind of societal value. In my experience in healthcare, we do a very bad job in the United States at thinking about the policy tactics around societal value. We do a very good job of thinking exactly what we don't want or what we really can't handle as a society, and that's part of this conversation around trade-offs. I think John Rother brought up a conversation around the consequences to other areas and other sectors. I think our third panel, especially touching on Medicaid, and it's interesting, Dr. Dietrich's from the state of New York. New York had released, their Medicaid program had released some of the preliminary guidelines around how patients should receive some of these breakthrough therapies, and in particular, Sovaldi. And it's highly restrictive when you actually start to read kind of the detailed script. Whether that's a precursor for many Medicaid plans across the country is exactly the question. I've talked with senior officials from delivery systems. I take a lot of time to work with delivery systems. There are many like Mount Sinai that are going into their own insurance products as well, and they're completely faced with this conundrum of providing what they feel is kind of their value to patients, while at the same time having very clear year-to-year budget implications. So the other point that I don't know if it'll come up at some point, I think some of our panelists will try to make this, but one point that I definitely wanted to raise is that we've talked a lot about the kind of sticker price in previous conversations in the media and some of the articles that Dana flashed up in his presentation around $84,000. That's actually, it's a lot like buying a car. You don't actually pay that price. And so the complications of pricing, the interplay not only between Medicaid and best pricing programs, what manufacturers can do, what insurance companies do, it's a very opaque process to almost everybody, including most people in the healthcare system. I would guarantee that if you actually polled most of the doctors who are dealing with these drugs in their systems, they don't understand exactly the pricing and spending consequences. We've known that to be true for care for other conditions. A survey that was done across 19 states of 600 exchange plans that were offered this last year revealed that the vast majority of them had at least a 30% copay for patients for some of these drugs. So again, these are nuances that don't get really appreciated when we start talking about a $1,000 pill and how we think about the return on that investment from the standpoint of a manufacturer, as well as the standpoint of an insurance company, a patient, and then the delivery system in which they're in. There have been many, I think the third panel will get into alternatives for financing, so I hope that we don't spend too much time time on that, but a number of the proposals, I think Dana just tossed out one for breakthrough therapies, a number of other proposals mimicking the veterans' price negotiation ability, talking about how to change the best price regulations and apply flexibility or waivers. It's interesting that CMS just announced in the last several weeks that they're looking at allowing accountable care organizations to explore flexibility with Part D plans and how they would include Part D drugs in this. So it's a very interesting time. But again, it gets to what we're good at and what we're not good at in the United States with societal trade-offs and having deeper discussions. But hopefully all of us can keep in mind, I think, something that our previous panel highlighted, that it's really kind of at the intersection of clinical care as well as very serious financial consequences that we're struggling with this issue. So let me I'm going to also copy Alice because it's always a good thing to do. We'll have our presenter, Darius Latkavala, who's from the USC Schaeffer Center for Health Policy and Economics, where he holds the Quintiles Chair there, and he'll do a brief presentation, and then we'll go ahead and have our panelists join us. John Milligan, the President and COO of Gilead, Ryan Clary, the Executive Director of the National Viral Hepatitis Roundtable, and Sam Nussbaum, who's the Executive Vice President for Clinical Health Policy and the Chief Medical Officer from WellPoint. And to one of the audience's questions around data, I think Sam is going to bring us some data as well, so we'll have him present some slides after the panel comes just to illustrate some of the points that we've all been speaking about this morning. So, Darius, here you go. Thank you.
Okay. Thank you very much, Kavita. It's an honor to be here. One of the challenges of following a fantastic panel is that there's so many great points that get made. It's now I have to figure out a way to be innovative and novel and make some new points. But in fact, what I'm going to do is pick up on a few of the themes that were emphasized in the earlier discussion. And in particular, I want to focus on the point that was made, and that is the question of whether the payers that are bearing the costs of these treatments are also the ones who get to enjoy their benefits. And I want to begin by explaining why that's an issue in healthcare with a couple of examples that illustrate the point. So let me begin with an example where costs and benefits are well aligned and things work out very cleanly. And it's a disease called acute coronary syndrome, which is a disease in which there's a sudden reduction in blood flow to the heart. A typical therapy for this type of condition would be a stent plus a blood thinner. So there was a well-known blood thinner called Plavix that was launched many years ago. And while Plavix was on patent, it was a fairly costly drug. So the question you might ask, or certainly was asked at the time, is it worthwhile for payers to cover Plavix generously and make sure that their beneficiaries didn't have to pay high co-payments or out-of-pocket costs? So in this case, the use of Plavix in the hospital after somebody has an event and the generous coverage of the drug that allows patients to stay on it and continue to refill their prescriptions pays very immediate dividends. So the graph shows you that over time, within just a 12-month period, there's a significant reduction in rehospitalization rates for insurance plans that provide very low out-of-pocket costs to their patients and then stimulate the use of this drug more regularly and continuously. And it turns out that this reduction in rehospitalization pays very immediate dividends to the plan that covers Plavix generously. So this shows you that within 12 months, a plan that covers the drug generously saves about $2,000 in terms of reduced hospitalizations at a cost of about $1,500 extra in drugs, for a net savings of $600. So this is a nice, beautiful, fantastical example where everyone's incentives are aligned. The payer covers this drug, it's effective, it helps patients, it keeps them out of the hospital, and the payer is around to see the return within 12 months, and their patients are still with them within 12 months, so everything works well. But of course, not every disease looks like this. Here's another example that's a little bit harder to deal with, and that's type 2 diabetes. So this curve shows you the occurrence of complications among patients with type 2 diabetes, and it demonstrates how over time these complications emerge. The different curves correspond to patients with more or less tight levels of blood sugar control. The blue curve shows us patients who have very good blood sugar control, and the red curve shows us patients who have the worst blood sugar control. Initially, over the first couple of years with the disease, there's not a huge difference in complication rates between the really well-controlled patients and the poorly controlled patients. But when you look out over, say, a 20-year horizon, there's a very, very big difference. And the people with very poor blood sugar control have 2 to 3 times as many complications as the people who started out with really good control. So here we have the problem that if you're the payer who is working really hard in years, let's say 1 through 3, to make sure that your beneficiaries are controlling their blood sugar tightly, you might not be around to enjoy all the benefits of that 15 and 20 years down the road. And the problem with that, of course, is that there becomes insufficient incentive to invest in these kinds of treatments that produce very long-term benefits, because we've decoupled the firm that's paying from the firms that enjoy the benefits. And what has been pointed out in the first panel, and I'll show in more detail, is that hepatitis C is a little bit more like type 2 diabetes than it is like acute coronary syndrome. That we're going to have a situation where some payers are burdened with disproportionate shares of cost and not enough of the benefit that's truly flowing to the rest of society. So you have growing pressure to limit access in ways that are probably inefficient. And there are at least 2 reasons for this. One is that hepatitis C complications take many years to develop. So oftentimes the payer that's paying for treatment might not be around to see the advantages of reduced complications in the future. And the second point is that hepatitis C has been noted as an infectious disease. So treating a patient with the disease today helps a lot of other people who don't get infected because of their encounters with that person. So you have another set of people who are not in any position to pay for the benefits they're receiving. So that you have various kinds of misalignment between the folks who are paying the cost and the folks who are accruing the benefits in the future. So let me make one important point here is that most hepatitis C patients are covered by private insurers or are in fact uninsured. So the 2 pie charts show you under the current system, the significant majority of people currently with hepatitis C are on private coverage or without any coverage at all. What the ACA will do is move a number of these uninsureds into private coverage. But the problem is that there are only about 15% or so of the Hep C population that's covered by Medicare. And the trouble with that is that Medicare is really the one system where people stick around for a really long time. Private insurers, on the other hand, the average tenure that private insurance can expect, of course, it varies from firm to firm, but on average, we're talking about 3 to 5 to 6 years. So if you're a payer that's paying for treatment today, you would like to see returns on that investment within 3 to 5 or 6 years. And that may not be the case in a disease like hepatitis C, where a lot of the benefits accrue well into the future. And as I'll point out later, this really just exposes, I think, a key limitation of our current health policy regime, in which there's so much turnover within the private health insurance system and no way to kind of bind patients to their payers for a long period of time. So if you look at this, at what's the consequence of this fact that there are relatively few patients in Medicare or in this long-term payer we call Medicare, think about the 3 treatment scenarios that Dana put up: the treat 5%, the treat advanced patients, and the treat all scenario. This graph shows you the cost borne by different kinds of payers in those scenarios. The green bar is how much cost is borne by private payers. The yellow bar is Medicaid, and the gray bar is Medicare. Now, if you look at all these bars, it's clear that Medicare is the shortest bar, and it turns out that Medicare is bearing only about 15% of the cost. So that means, just to boil it down, about 85% of the cost of treatment, roughly speaking, is being paid by payers that aren't really going to be able to retain their patients for more than a couple of years. That's why this is a particularly pressing policy problem here, because there's I think, a fairly extreme disconnection of the benefits from the cost that requires, I think, some serious policy discussion to remedy. Now, the kind of assertion has been made that the benefits of Hep C are kind of long-tailed benefits, and I want to show you specifically why people are pointing that out. So these graphs show you mortality over time for a cohort. This is from a study that follows a cohort of hepatitis C patients in Taiwan for several decades. So it's a very interesting study. It shows you how mortality rates change over time. And Doug pointed out in the earlier panel that all-cause mortality, even from non-liver disease-related causes, is significantly higher among people with hepatitis C. So here's how you can read these graphs. The red curve is for hepatitis C patients who have detectable levels of virus in their blood. The aqua or blue curve is for hepatitis C patients who have undetectable levels. So these are successfully treated patients. So the gap between the red and the blue shows you essentially the benefit of treatments that can cure the disease or wipe out the virus in the body. And you can see that over the first, say, 4 to 5 years, there's not a big difference between the blue curve and the red curve, particularly when it comes to mortality from liver disease or even when it comes to all-cause mortality. But when you look out 20 years, you can see that if you wiped out the virus in a bunch of hepatitis C patients, you would have saved about 1 in 10 of them from liver-related death, and you would have saved almost 1 in 5 of them from deaths by any cause. So initially, there's not much of a gain to the people bearing the cost, but in the long run, there's a huge gain, which is where the value of this therapy comes from. Now, there are other advantages, too, besides mortality, and one of them is that Hep C is a leading cause of liver transplants. So about 40% of the people on the waiting list for livers in the United States have a Hep C diagnosis. So what does this mean? Well, this is another instance where treatment has a long-term benefit of, in this case, avoiding liver transplants. So the left-hand graph shows you the risk of liver cancer, which is a cause of or for a need for a liver transplant. And again, you see the red curve is uncontrolled Hep C or poorly controlled Hep C. The aqua or blue curve is well-treated Hep C. And you can see that over time, the risk of hepatocellular carcinoma rises quite rapidly in the red group relative to the others, but for the first couple of years, there's not a big difference. So for all of these reasons, there's first of all, a timing issue, that the people paying for treatments initially aren't necessarily around to enjoy the benefits of those treatments because most of them are private insurers or Medicaid programs that don't retain patients for very long. Now, there are other issues besides timing as well, and that were also alluded to, and one of these is that because Hep C is an infectious disease, our treatment of patients, particularly those who are at high risk of transmission, so patients who are, say, IV drug abusers or HIV-positive men having sex with men who have relatively high transmissivity risk, treating the disease successfully in those groups could prevent thousands of new cases annually. So this is just a simple, rather crude back-of-the-envelope calculation using some of the results that Dana presented, that if you take the rates at which Hep C patients infect others and you perform the thought experiment of curing the disease in some of those patients, it turns out that curing the disease in, let's say, 5% of Hep C patients could prevent about 1,000 cases of the disease annually in other people. Now, obviously, people who are uninfected and have Hep C disease prevented have no way of paying for therapy. So this is another disconnection between the folks who are deriving benefit and the folks who are bearing cost. And the final example I'll give you is from an entirely different group, and that is, suppose you treated 5% of the Hep C population. Previous research on this subject suggests you'd avoid about 1,000-ish liver transplants. Now, it turns out there are about 15,000 people on the waiting list for livers in the United States. So that means that treating 5% of the Hep C population gives an extra 1,000 people on that waiting list, some of whom don't even have Hep C, livers that they would not otherwise have gotten. So all of those spared livers get put to good use, and that's another group of people that is disconnected from the cost but deriving benefit. So what does all this mean? So it's also, recall I started this talk talking about type 2 diabetes that had a similar timing problem. So what the heck is so special about hepatitis C, and why is it called the tip of the spear or the canary in the coal mine? Well, here's, I think, a calculation that demonstrates what the big deal is. So the green curve is taken from a study of French HIV patients. So there's a study that shows if you look at a representative cohort of French HIV patients and you track the cost of treating them over time, what would it be? This is about 7,000 patients or so, and the study demonstrates that it costs about $100 to $150-ish million a year to treat this cohort of 7,000 HIV patients indefinitely, because the treatments in this case are chronic. Now let's perform the thought experiment where instead of having 7,000 HIV patients, suppose we instead looked at 7,000 Hep C patients, and we treated all of them in the same way that we're imagining treating these HIV patients. Well, here's the difference. For Hep C, you would incur a cost of over $700 million in year one and essentially nothing in the out years. This is a crude calculation, but I think the point is a valid one. Over a 20-year horizon, the Hep C treatment strategy looks like a great deal because you've avoided the need to spend $100 to $150 million a year in perpetuity. But that's not necessarily much consolation to a payer who's around for only 2 or 3 years in the beginning and picks up all the costs and none of the benefit. So really the fundamental policy problem is how to align incentives. And I think one of the other general points that I want to close with on this slide as well as some future directions, I think we have a health policy regime in the U.S. that has been pretty successful, if not very successful, at generating scientific innovation. So innovations that make meaningful differences in the lives of patients and in both quality of life and quantity of life. But I think historically we have not done such a good job of encouraging innovation in pricing. In fact, in many ways, the regulations that we have in place stifle creativity and make it very hard to innovate in pricing. So we need to move to a model where we can find new strategies for aligning costs and benefits in a manner that's consistent with a more rational health policy regime. So I won't try to steal the thunder of the third panel, but just kind of put out a few points that maybe provoke some discussion from here on through the rest of the day. How could we better align costs and benefits in Hep C and other related diseases? Because this is by no means the only disease that has problems like this. Well, for one thing, we might help Medicaid programs smooth their costs over time by helping them access credit markets that let them borrow against that essentially open up a line of credit that let them pay today for therapies that have this lumpy nature. This is an idea that Tom Phillipson, who you'll hear from later, has advocated. You can think about solutions in private insurance markets. For instance, you can think of handoff payments. Suppose that I'm an insurance company that has treated a bunch of my Hep C beneficiaries. They're very healthy now, and then later they switch to one of my competitors. I've handed them over in a much healthier, lower-cost state. Shouldn't I get some of the credit for doing all that work up front, investing in treatment and making them healthier? Shouldn't I accrue some of the reductions in cost that they'll experience over the balance of their lives? So you can imagine the new insurer paying the old one essentially for some of their trouble. There may also be a role here for public subsidies. Dana mentioned this point. There certainly are aspects of this problem that go beyond timing and cover benefits accruing to completely different groups of people who aren't even patients. And that usually means a role for subsidies or public agencies or payers. I think it's beyond the scope of my discussion to go specifically through each one of these examples, so I'll instead just put those on the table to ignite some discussion and lively debate over our session and the remaining session. So now I think I'll step aside, and I look forward to hearing from my colleagues on the rest of the panel. Thank you.
And why don't we go ahead and have the panel join us, and then I know Sam has some slides, so I think, Sam, you're going to go last, so that we'll reserve that so that we can have folks turn if they need to, and we'll get mic'd up and all that. Yeah, absolutely. And let me make sure.
That's the one that works.
John, why don't we start with you? I know you wanted to walk us through a little bit about, you're probably the one person that can kind of walk us through some of the company's perspective, as well as just some of the frank conversations around pricing that we want to have in this panel.
Sure. First of all, thank you for having me here today. It's a pleasure to be able to talk about Sovaldi, which is obviously a terrific drug. That's the reason why we're here. It's better to be talking about a drug that's universally acknowledged as being a breakthrough designation. And I'd like to provide a little bit of our perspective on how we got to the price that we did, and some of the considerations that we put into the pricing, and some of the things we did not put into the pricing, as well as something about the value we think we're bringing in this area. I think, John, you mentioned value, as well as the future of where we're going and where I think pricing is going to go in this industry. I will say it's a very innovative time in hepatitis C. There are more breakthroughs being made more frequently than have ever been made in this field, and it's been a very historically difficult field to come up with medications. We have been able to cure patients for a large number of years. Over a decade, we've been able to cure patients. But as it turns out, it's a very small percentage of patients who can be cured. Some sets of patients can't be treated at all. And many patients fail at a great cost to the system, as Dr. Dietrich alluded to in his system in particular. And so with Sovaldi, what we saw was a way to have a therapy that was in shorter duration, that had higher cure rates than had previously been documented, and had the possibility of being used across a wider range of patient types. And those things all factor into the way we think about it. Higher percentage of patients cured, so that's good. Shorter duration of treatment, which lowers the cost of other therapies. Fewer side effects, far fewer side effects, in fact, than the currently available therapies at the time we were studying Sovaldi. We didn't take many of these things into account. We didn't take into account the higher cure rates. We didn't take into account the fact that there are far fewer additional medications that need to be given with this that can drive the cost, as Dr. Dietrich said, in upwards of $185,000 per patient, admittedly in very difficult patients. We did know that this was going to be a better experience for the patient. More patients would get through. We saw that in our clinical studies. We're now seeing that in our surveys of the field in general. And we looked very hard at what value we were bringing to the system. But at the end of the day, the pricing analysis was relatively simple. What is the current cost of other therapies? We looked at telaprevir, also known as Incivek, plus pegylated interferon ribavirin for 24 weeks. We looked at the price of cimeprevir, a product that had been launched just a month before our product, plus a range of 24 to 48 weeks of pegylated interferon ribavirin. And those cost about $96,000 for a regimen. So we looked at the regimen cost. Sovaldi plus 12 weeks of PEG-RIBA costs about $94,500. So it's roughly in line with current therapy. So we were providing more value, better outcomes, shorter duration, better patient experience at the same cost of the standard of care. So that was simply how we looked at it. We don't look at return on investment. We don't look at we don't look at the sunk costs, where none of that goes into the pricing. In fact, I don't know a single firm that uses that as a metric for how we determine. Our field is very expensive. Drug development is very, very expensive. We spend a lot of money up front, and we do it all at risk. And sometimes it works out, and sometimes it doesn't in our field, and that's one of the things that's difficult about the pharmaceutical industry. We do take that into account as we think about where we're going to allocate resources, but that's not the primary reason for the pricing of Sovaldi. It was principally driven by the current standard of care. We thought long and hard about the value we were bringing, though, and it's been a funny debate that's gone on in the press since this time, because as I think about the value story, I think about the efforts of people like Dr. Dietrich, who work long and hard to cure patients of hepatitis C, going to great lengths with great amount of staff and supportive care. We've never questioned the value. Is it a worthwhile thing to cure somebody of hepatitis C? There have been enormous numbers of studies and cohort studies. There's been studies, for example, in Kaiser, showing the value of curing hepatitis C and showing the cost savings of hepatitis C. So one thing on Darius' slide, he showed the cost going to zero if you treat everybody, for example, in a 7,000 patient cohort. But if you think about it, if you hadn't treated those patients, they would have costs associated with them. You look across some of the closed systems like Kaiser, and they estimate that you've got about $7,000 per annum cost in a patient with hepatitis C who has otherwise no other hepatic manifestations. That's a fancy way of saying liver symptoms. So that's just to say that it's costing you something. As you start to have those liver symptoms, hepatic manifestations, the cost goes up pretty dramatically. So if you think about the cost of Sovaldi versus the cost of a patient who otherwise doesn't have any hepatic manifestations, you get your money back in 12 years. Probably more than that, because the disease is going to progress. We thought long and hard about the cohort of patients in the United States, the baby boomers, and they are progressing. Dana Goldman showed a very nice slide showing where the cost is going to come in, and the cost is coming for those patients. We can look at Japan as an example of that. The average age of a patient with hepatitis C in Japan is about 10 years older than the United States, where the cost of treating hepatitis C is going up very dramatically because there haven't been cures in the past. Liver cancer is the #1 cancer in Japan right now, and it's all caused by hepatitis C and by people who've had the disease long period of time. So we see a baby boomer cohort that's growing, that has an immediate need to be cured, especially those patients who've had the disease a long time, whose cost per care is going to be dramatically different in the future versus that which it has been in the past. And so we know there was an urgency for this to bring our product to market. We worked very hard to bring in Sovaldi as a stopgap between where we were with very difficult interferon-containing regimens to the future, which will be all oral regimens. There's some really dramatic changes coming in the field and coming very soon. In fact, the study we did in genotype 1 patients, the most common patient in the United States, was really a stopgap. We knew that interferon wasn't long for this world, but we did know that patients would want to have something in the interim that they could look to be used. We've been surprised at the response. We've been surprised at the volumes that have occurred. Drug development, usually when you look at how patients rolls out, doctors are typically a little bit reluctant to be early adopters. They try it on a handful of patients and slowly see if the medicine works the way it's advertised, and then they'll put on more patients. Doctors believe the data and brought in patients in really record numbers over the first half of this year in terms of the number of patients treated. It was a remarkable uptake of a drug, far more than we expected. Far more patients were still willing to go on 12 weeks of interferon than in years past. That was a surprise to us. Far more patients got cimeprevir and sofosbuvir. That's a combination that's been studied in phase 2 clinical studies, but there's no data supporting it in any FDA label for our product, sofosbuvir, or Janssen's product, cimeprevir. And yet it's been used in a wide number of patients, sort of underscoring the unmet need for an all-oral regimen. That regimen costs about $150,000 at its WAC price, by the way, so it's a very expensive regimen. But as Dr. Dietrich said, it's very effective in his hands and in the hands of many others. So it tells us where we're going. So where are we going? And this is the last point. Sovaldi is a stopgap that's going to then lead to all oral regimens, which I think will lead to shorter treatment durations and better outcomes for patients. We have a combination product of ladipizvir, sofosbuvir. It's 2 medicines in 1 pill given once a day. We have it under review with FDA, and we have a PDUFA date of October 10th. So a week from Friday, we should get approval for the product. This product has a couple of attributes that are important. One, even higher cure rates. We've seen cure rates between 95 and 97% in most of our clinical studies, including patients who have significant evidence of cirrhosis. We also have an 8-week regimen available for patients. 8 weeks of therapy for patients who have relatively low liver disease, so no cirrhosis, and have low viral load. We can segment that, and we know from our studies that 97% of patients who take this 8-week regimen are cured. And that 8-week regimen will be accessible to about half the patients in the United States who have HCV. So that means that the price will be 2/3 of the price of what it is for a 12-week regimen. And it's our intention to stick with our original principle of pricing in the ballpark of what the current standard of care is. So what you're going to see in the future is new regimens, new innovation as we continue to invest, new options which will drive the duration down, which will drive the cost down as well. And so this is a continuation of our industry trying to innovate to bring better treatment options, higher cure rates, and lower costs, and that's where we're headed. And those are really the 3 points I wanted to make, so thank you very much.
Great, thank you, John. Ryan, and something that I didn't mention, you can look in Ryan's bio, the intersection with the CDC recommendations was something that you and your group had a lot to do with. So there was, John, to your point of doctors tend to be late adopters, or at least to try things with a smaller group, there was also a pretty clear recommendation for patients who were born between the years of 1945 and 1965 for universal screening, which has also had an impact on how we approach kind of thinking of identifying kind of the 3+ million patients. So Ryan, your perspectives from both a kind of population as well as a patient standpoint.
Sure, thank you very much. Thank you for having me. I've been looking forward to this discussion. I'm with the National Viral Hepatitis Roundtable. We're a coalition of hepatitis B and C advocates around the country. So I have the responsibility and the opportunity to provide the hepatitis C community patient perspective point of view, and Margaret talked about the importance of having the patient voice, so thank you for letting me be part of this discussion. It's a voice that's really been lost in the past several months of what's been really a media barrage as we've seen the headlines about this story, and what's been lost is about the great hope and the opportunities for people with hepatitis C to be cured of their chronic infectious life-threatening disease. So when Sovaldi was approved, those of us in the field thought we were entering a really very hopeful time that we could implement the CDC and the U.S. Preventive Services Task Force's testing recommendations and encourage people to be tested and linked to care and bring back folks who hadn't been successful with treatment before because of what we've just heard about, the high cure rates and the low side effects. And instead, the message that we wanted to get out was really taken over by what was really a sustained PR media campaign, largely driven by the healthcare industry and supported by coalitions and organizations and some medical groups who had never shown any interest in hepatitis C until this year, to really highlight the $1,000 a pill drug and to use this as an organizing tool around a much larger issue. And that's really sapped a lot of the energy and a lot of our efforts as we've had to now fight against misinformation and stigma that's been perpetuated in the media about who deserves treatment and who doesn't. And I asked folks to think about why this conversation happens around hepatitis C and if it really would happen around other diseases that didn't largely affect people who inject drugs, either currently or previously. So the losers in this discussion where we talk about value and price versus who gets access are people with hepatitis C, who deserve to be cured if they want to be cured in consultation with their doctor for a variety of reasons. So I think we really need to reframe this discussion and not think about the 3 million or 5 million or how many people have hepatitis C in this country as this sort of faceless, unnamed group, but as people. Many of us have been impacted by this disease. We have relatives and friends and mothers and fathers and coworkers and colleagues who are living with this disease. And that's the lens I think we need to be having this discussion through. And we talked about that with ALS. These are real people who, regardless of where they're at in disease state or where they're at in their life, probably would like to be free of one thing in their life that's causing a problem and causing anxiety and making them worry about the future and the potential to infect people who they care about in their community and in their family and their loved ones. So to speak about the impact on private insurance, there is absolutely no doubt that there's an impact and a heavy cost to private insurance. It's an expensive drug. I'll talk about that in a moment. I would argue that that's kind of the cost of doing business in private insurance. That's for private insurers, insurance companies who are in the business of making a profit in the healthcare insurance industry. Sometimes you're going to have a high cost. They make a lot of money off of people like me. I'm 45 years old, relatively healthy, almost never go to the doctor, been paying premiums, or my employer has, for my entire life. And I go once or twice a year and I have a couple of generic prescriptions. So the 3 to 4 insurance companies I've had have made a killing off of me. We don't talk about that in this discussion. So that's the cost of doing business, is you have people that you have to pay for and people that you make a profit off of, and somewhere in there is the mix. The public programs, the state Medicaids, that's a different story. These are programs who are not in the business to make a profit off of healthcare. They're in the business to provide healthcare to low-income people, many in vulnerable populations, who are in a safety net program and do the best they can with strapped budgets. And they're having a real hard time providing access to Hep C treatment. They don't pay $84,000. They get significant price relief, but they're still having issues. The problem with the state Medicaids is they reacted so quickly to the PR campaign and the misinformation and quickly implemented really harmful, not all Medicaids, many, harmful restrictions that are blanket restrictions that are discriminatory, particularly towards people who either currently or have recently injected drugs. And those are folks who probably would like to be cured of hepatitis C and not be transmitting to others. So that needs to be dealt with. And as far as the price, my organization and our colleagues have been on record. The price of Sovaldi is expensive. It is too high. The rationale makes sense, but when you look at the sheer number of people who have hepatitis C, who we know have hepatitis C and you look at the cost of treating everybody and curing everybody, we're not going to do it in the next couple of years. We know that, trying to get through that misinformation. But that's a really high cost, and we've encouraged lower prices. We're hoping that the next wave of prices, and it's not just Gilead, we have other companies coming on board, really look at the access problems that we're having, understand that price does play a factor in treatment access, and make decisions based on that. It's a fantastic drug. This all comes from the spirit and the hope that we can cure everybody with hepatitis C who wants to be treated. I vote for the option of treating everybody with hepatitis C, by the way. That was up there. So really, what we've been calling for in the community is exactly what Margaret talked about. We want an adult discussion among all the stakeholders. We have so many in the room, and we have most of the stakeholder groups right on this panel. I know all of our goal is to cure people with hepatitis C. We have some great new ideas that have already been floated, I think more in the next session. So can we all come together and bring in real medical experts, the community, government has a stake in this through implementation of the Affordable Care Act, researchers and academics who we've seen today who have a clear interest in this issue, and work on some short-term and some long-term goals that, at least on the advocacy side, we could have a game plan to be able to go out and fight for some relief to state Medicaids or whatever the short-term and long-term goals might be to be able to fix this problem. Because really the question that we should ask is, now that we have the tools that are here to eradicate hepatitis C, and I'll just say domestically for now because that's the lens I look through, and I'm not the one who came up with that statement. It's the researchers who identified the hepatitis C virus stated this in June at a meeting. The tools are here, but do we have the political will to implement them? So are we going to come together and work towards a plan, not in the next year or two, but over time, eradicate hepatitis C, take care of one problem in this country, let people get back to good health, save money down the line, and address other problems? Or are we going to just pick at the problem and just treat some people, and in 10 years we could come back and have the exact same conversation? This could be the model for how we address the other specialty drugs coming down the line, high-priced drugs, drugs that can actually cure people. Such an exciting time in innovation, but this really, instead of thinking about this issue as sort of the problem that needs to be fixed, think of it as the model that we can set to be able to replicate for other disease states and other innovative drugs that come down the pike.
Great, thank you, Ryan. Dr. Nussbaum, I know you've got some slides with some of the data that people have been asking for in the last couple of hours. Would you like to do it from the podium?
No, I think we can, Kavita, we could sit here, and then there are just some slides at the end that I know our panel has seen, and so they've seen the
That's fine,
already.
However you want to do it.
No, thank you. Indeed, I really appreciate the opportunity to be here and both inform this adult conversation, the dialogue, and actually probe some of the vexing issues that we face as a nation. Because there's no question, let's just all celebrate that medications, particularly breakthrough drugs like Sovaldi and others, have saved lives, have improved lives in immeasurable ways for individuals and populations. There is no doubt. There's also no doubt that we have an ecosystem, our academic environment, our discovery environment, our environment of extraordinary health centers, of advocacy groups that are engaged, that truly is an opportunity the world envies. So let's make that clear, and let's also make it clear that it's the robust private sector that we have in healthcare that has led to this discovery. But I think that as we've asked the questions today, I wonder if we're really asking the right questions, and let me provide some information. If we look at the average family wage in America, the earnings, over the last decade, it's been rather static at $49,000 to $50,000. There's been no movement. Healthcare costs for the average family, whether paid by the individual or more often the employer, has gone from $9,000 to $22,000. So basically, the economic vitality of our workforce in America is being limited by our extraordinary growth in healthcare costs. So it's not a question of whether a pharmaceutical or device company should be rewarded for a breakthrough product. They should. Gilead should be rewarded here. It's not a question of whether we as a society should want to invest in these products. We should and we must. But the real question relates to, is this trend of ever increasing more expensive medicines and increasing healthcare costs sustainable for individuals and for our nation? And we've already heard about trade-offs, but think about this. There's significant research that says that our illness burden is 30% genetic, and we can't choose our parents. It's 40% environment and our behaviors, and we can choose those. But basically, the healthcare we receive plays a minimal role in actually how healthy we are as a nation or how healthy we are as individuals. So can we design, out of this information, a system and a model that correlates value and price and enables us to invest in what we call the social determinants of health, education, housing? That will have much more profound effect on ultimate health than, in fact, some of the direct investments that we make in technology. And there are another set of realities just at play here. The United States pays a disproportionate share of discovery and drug costs. So for comparable drugs, our prices in the US are about 50% higher than other OECD nations. So we're not talking about developing nations where there's certainly policy and other certainly moral implications of getting access to drugs. But of the OECD nations, we pay a disproportionate share of development. So for these reasons, and there are others, that we pay more for health care than perhaps we should as a nation. The other issues that I think are relevant is we've heard a debate that pharmaceutical costs are actually falling for our nation. So let's inform this fact. It is true that if we look at traditional oral therapies, because of patent expiry, the medical trend, the pharmacy trend in those areas is down a few percent over the last years. But if we look at the specialty pharmaceuticals, that trend is up at over 20 to 25% of each of the last few years. So if you show that first slide, which should be in back of me now, overall drug spending in the United States this year, 2013 actually, is $330 billion. It's projected with the growth of specialty drugs, the total drug spend of just specialty drugs alone will be $400 billion by 2020. So basically, the cost of specialty drugs will eat up every other investment that we would make in our healthcare system. So it is really important to recognize that pricing becomes essential. And many of these other specialty drugs are not necessarily breakthrough drugs. They're drugs that have some incremental benefit, but probably should not be taking up all those costs. And you've heard from John, I think you described it so well. How do drugs get priced? And what I would describe it is that pricing is kind of a race to the top, not a race as other technologies are, that when you're introducing new technologies, often that technology lowers cost, whether it's hopefully illness or information technology or consumers. So let's take a look, and Kavita, I think you described this as an opaque process. If we look at the next slide, you're going to see our real-world experience with hepatitis C treatments. The first thing to recognize is that this is based on several thousand individuals treated since these new drugs have been approved over the last 10 months. And what you can see is that almost 40% of patients are actually being treated with combination oral therapy that has completion rates of 94%, so that's extraordinarily positive. But the cost is not $84,000. That's been out there. The cost per treating a patient is $160,000. You can also see that if you look at the non-oral treatment programs, that actually the completion rates, and this is again pharmacy fill rates, are far less than the 94% and range from 70 to mid 80%. So I think this is really important to see that the clinical experience of how these drugs in the real world can certainly inform our path forward. You've heard about the impact of the cost of these drugs on Medicaid programs and states, but what I'd like to do is talk for a moment about value, because almost every part of the healthcare system is moving toward value-based payment, whether it's ACOs, whether it's gain sharing. In fact, we believe that 50% of total dollars will be in value-based payment arrangements by 2020. Today, at WellPoint, we have over $30 billion, almost 36% of all of our spending in value-based payment arrangements. But what's fascinating is that drugs are the outlier. Drugs are really a price and volume business. So we know when there's competition in a market, it can work. But what happens in that very first phase? So let me try to suggest some ideas that will lead us toward solutions. First, I think it would be helpful to understand how the insurance system works, because I think there has been some information out there that is at variance with how it works. Now, I'm speaking from WellPoint. We are the largest commercial insurer in America, so call it, almost 30 million commercial members. And we also are the largest Medicaid insurer in America. So we see, firsthand how this system works. And there's some elements of it. First, on the commercial side, what many people don't realize is that more than half of the commercial business is actually not what's termed fully insured business, but large companies hold the cost of advancing healthcare and technology. So they're basically having us do care management, contract for services, create networks, but they hold the checkbook. And so it's in that setting that there's tremendous employer pressure on maintaining costs. In addition, we generally set rates 12 to 18 months in advance. So the more knowledge we can have of a drug's cost, and you've seen a great example that we have another, I believe, exceptional advance being made in hepatitis C therapy, and we're weeks away and we don't know what those costs will be. We have a range of what those costs will be. The other thing, and this I was mentioning to Alice at the very beginning of our session, is we are an industry that is under intense rate review on exchanges, that has rate regulation. So if you have one part of an industry that's regulated and the rest of the industry, whether it be providers, hospitals, technology, that is seeking very significant increases in cost, how does that system work? So what are then the considerations? And I sort of would like to share this on the next slide, I believe, as sort of a prelude to the discussion that we can have, but certainly for the next panel. And that is simply, I believe that simply deferring the cost down the road isn't an answer, because it just begs the question of how do we pay for the next innovative drug? And hopefully in an era of molecular biology and understanding our genome and personalized medicine, we will have many more. There are all the rare diseases that have not yet, treatments have not been identified. And value-based payments, something we all wish to achieve, has been difficult to pursue, and we need to follow that and identify the hurdles. So you have some strategies that I've and others have thought through. So bundled pricing, bundled payment for an illness. So we look at the whole longitudinal care, and you can look then at economic models of what liver transplant or the complications of cirrhosis might be. The use of value-based purchasing, the use of real-world evidence development, something that we and our subsidiary HealthCore are very focused on. What happens after a drug is FDA approved, how it's used. What are the economic models? You heard some really elegant work that was done at USC, but there are other models out there. The California Technology Assessment Forum and ICER have different models. So what are the right ways to evaluate the value? And then the final point is I think there are opportunities today to at least move us a little bit closer to policy and regulatory models that can help all of us. So for example, the timing of pricing. If we know it and can work with state governments and build it into rates and work with employers, we have, again, a path forward that will not disrupt Medicaid, for example. I think most people don't recognize, but the margin in Medicaid businesses are in the very low single digit. So a breakthrough drug or, again, a viral outbreak can absolutely put those Medicaid health plans and Medicaid budgets at risk. The other approach is advance knowledge about the indications on the FDA label. We have heard some good news here that maybe half of the people with hepatitis C that have earlier stage of disease, that have, again, type 1, can be treated with shorter durations. We know that from the science, but that's information that doesn't become readily available until we see that label. And I think the other piece, and we do have dialogue between the insurers and pharmaceutical companies, but the more robust and open that dialogue can be, through regulatory allowance, I think we can do more to work together to ensure that Americans really and the world gets the drugs that they need. So here's my concluding comment, is that yes, it's great to have dialogue, and we need absolutely to work together, and thank you Brookings and thank you USC, to develop standards and an understanding of what metrics that we can judge and pay for innovation. But what I'm concerned most about, and I've seen this when we look at state government and employers and around the nation, is that the cost of new therapies can jeopardize the very innovation. It's the hallmark of the American healthcare system. And we must not let that happen. Thank you.
Great, thank you. Before we open it up for questions, I wanted to just give Darius a chance to react to any of the other panelists. And maybe, Darius, while you're collecting your thoughts, just to touch on something I'm going to kind of address personally with each of the panelists. John, I wanted you, it's been brought up in a little bit of here and there, but the allusion to kind of the domestic versus global impact. So that's one piece, kind of how, when you think about the pricing and what happens for products in other countries, how that might have an impact on domestic pricing. So that's for you. And then Ryan, for you, just you mentioned a lot of the kind of the campaigns and fear-mongering. My experience with patients at a very practical level is that they are highly cost-sensitive. You already said that you had a statement about the drug being too expensive. How do you think, and I'm not asking you to have an answer, but how do you think then about what is appropriate pricing and how, putting aside the fear-mongering, we all still are left, especially in a city like Washington, with trying to come up with thinking about price controls or regulatory frameworks. Has there been a conversation at the patient level about how much is enough? And so that's to tee up for you. And then just Sam, for something for you to think about, you've mentioned the proliferation of value-based payments. Something that we can't anticipate is when the next breakthrough drug might come and how that might have an impact on your industry. So can you give us some examples of how you're seeing some innovative relationships between kind of these value-based contracts or value-based insurance design, where it is kind of taking not just the cost of drugs into consideration, but kind of the total, as you framed it, kind of the total cost of care. So I'm just lining that up so that no one's getting thrown by surprise. But Darius, any thoughts or reactions or other questions?
Thank you, Kavita. So what I wanted to just talk about just for a minute is this gorilla in the room of price, and thinking about how we take all of the comments that have been made and bring them together into a meaningful analysis of price. So from my perspective as an economist, and even from society's perspective, a price really, it's not a cause, it's an effect, right? It's an outcome of various kinds of things. It's an outcome of a cost. How hard is it to come up with a product? What's the market power of the buyer? What's the market power of the seller? What are the various institutional arrangements, et cetera? So taking that one step further, the question is, what are the right policy regimes that affect all of those underlying drivers of price? And it seems to me that Sam made a very interesting point that speaks directly to that. And his point was that value-based pricing is very important in so much of WellPoint's business, for example, but not in drugs. And it got me to thinking, so drugs is an area that where we heavily regulate the production of evidence. So more than any other part of healthcare, we know how to understand clinical benefits of drugs. We know much more about clinical benefits of drugs than other kinds of healthcare. So what's going on? Why do we not map that into pricing? And I think the answer is that we have regulatory obstacles to creative pricing. So Medicaid best price rules are commonly adduced as reasons why it's hard for payers and manufacturers of drugs to come up with creative schemes to compensate value. I mean, we certainly see value-based pricing overseas, And I don't think, as far as I can tell, I think many people are in agreement that we ought to be paying for value. And I also think that, John's point is a good one, that we're not debating the value of this therapy so much. This is clearly a valuable therapy. So, and value-based pricing means therapies like this get rewarded more. And as Dana mentioned, it means the incremental drugs, the specialty drugs, let's say, that aren't really producing a lot of value get rewarded less. All of that makes total sense. Why is it that a robust private market, as Sam pointed out, hasn't gotten to that point, and that we've instead been derailed, as Ryan mentioned, by this big discussion of $1,000 a pill? And I think the reason is that we've stifled creativity in pricing just as we've exploded creativity in science. And we need to remove many of those regulatory obstacles and let our private sector innovate pricing schemes just like we let them innovate new molecules and therapies.
Great, I'll start down this line. John, thoughts on anything as well as kind of the question about the global impact when you think versus the domestic pricing?
So let's talk about the global pricing structure for Gilead. I can't speak for the industry, of course. And the program that we're setting up in hepatitis C is a mirror of what we set up for HIV many years ago. Going back to 2003, when we had launched our first HIV product, we recognized that HIV was a global pandemic. Everybody had recognized that, with perhaps 40 million people infected worldwide. But many parts of the world, of course, unable to care for many of their patients. There was a growing body of evidence that you could treat in very poor parts of the world with very low levels of healthcare infrastructure and have very good outcomes. And as a result of that, we came up with an experiment. We decided to try to set up a tiered pricing model for the world, bringing in, from Gilead's perspective, regulatory approvals and a ceiling for a no-profit price in those countries for HIV. And we set that model up in conjunction with a series of licenses that we gave to the Indian generics industry, or the Indian pharmaceutical industry, I should say, where they could use their economies of scale and, in fact, their scale of manufacture and their business relationships to set up businesses with sub-Saharan Africa, with Southeast Asia, with other parts of the world. In total, about 131 countries, I think, at the end of the day, that they were allowed to sell into to try to increase access to therapy in those parts of the world. So we set up tiered pricing then beyond that. So that, by the way, that was a very successful program. And as of the last time I saw the numbers, about 7 million people in that part of the world were getting Gilead's HIV products, mostly through our generic partners in India. That is up from effectively 35,000 a decade ago. So it's a massive increase in the number of people being treated. So that was very successful. For middle-tier countries, for middle, upper-income countries, we use the World Bank definition of per capita GDP, along with some metrics around the incidence and prevalence of disease. We came up with a tiered pricing model that I think works fairly effectively for HIV. We're just trying something similar for HCV, and as you may have seen, we've set up a series of licenses now with 7 Indian manufacturers for about 90 countries around the world, where we will provide production and manufacturing specifications to allow them to accelerate production for that part of the world. The one partnership we've set up most recently, and I think is a really interesting model, is one with Egypt, where we are setting up a low-tiered price for Egypt. Egypt is a very unusual country in that a very high percentage of the people are infected, about 15% of the Egyptian population. They're principally infected because of a vaccination program many years ago in which they were reusing medical equipment. And they have an ongoing incidence. So the medical care is good enough that people can seek out things like blood transfusions and operations, but not so good that the blood supply is clean. So there's an ongoing increasing infection rate. And the Egyptian government believes there's about 300,000 key individuals who, if they could cure them, would stop the incidence pretty dramatically. And so this is an experiment we're working on with the Egyptian government to see if, through our program, through our public program, can we target a specific segment of society to really slow down the rate of infection in that country, which is pretty dramatic. So that's the principle behind what we're doing in Egypt. With regard to the rest of the world, we do have different pricing in different parts of the world. Europe tends to run for our products on average around 3/4 to 2/3 of the U.S. price. It depends on what U.S. price you're talking about and what product. If you look at our products in HIV, the price in England is about the same as the price of our ADAP program, and the price in England is quite low relative to the rest of Europe. So it depends on the situation, depends on the U.S. pricing. And U.S. pricing depends. I mean, for example, we talk about Medicaid. Medicaid, it gets a natural 23.1% discount. That's mandated. There's very little beyond that we can do in most states. The VA gets a 41% discount, which is consistent with our principle in HIV as well. So there are considerable discounts depending on where we are allowed under law to do those sorts of things.
Great. Ryan?
Sure. So the pricing question. So I don't pretend to have the magic number and the magic price that I think would suddenly make this problem go away, and I don't really know that number exists. Advocates meet with pharmaceutical companies all the time before a drug is launched, and we make the best case we can for the lowest possible price, showing how price has an impact on access. And advocates met with Gilead and made that case, and the price came in where it did. The rationale, as I said before, does make sense. The issue is that I think with older regimens, folks weren't thinking that everybody with hepatitis C might like to be treated and cured over time, and so it's a math problem. You start multiplying the price times what is expected to be the number of people. So I think that alone warrants consideration around price. And this isn't just for Gilead. This is for folks who are companies who are coming on board with new treatments. There are clearly discounts in public programs. There can be supplemental rebates for Medicaid. I believe in some states there have been. Sort of having that information transparency would help a lot with the process. But sort of the overall impact of price plus number of people expected to be treated just sort of warrants continued discussion about price. But I'll say again, I think price is just one of the factors in access problems, and I think I outlined a lot of the other ones.
All right, thank you. Sam?
Kavita, you asked about value, and Darius sort of talked about this too. Let me be clear. When we look at existing drug therapies and have information, we actually do look at the integrated financial and clinical value of drugs and make decisions for our formularies based on that. So a drug for childhood asthma that is more effective in keeping children at school and out of emergency rooms is one that we often will put in a preferred position on our formulary. The issue is, how do we determine the value of a drug such as Sovaldi or others that are in the $250,000 range or more? And what makes this debate difficult, and you heard it on liver transplants, yes, on the face of it, no one wants to get to the point of liver transplant. We're talking about $500,000, but in the United States we do 6,000 or so liver transplants, yet we have at least 3 million people that need to be treated. So you can't really build that type of economic value model for liver transplant. What we need to do, though, is to understand our goal is to treat people when it will make a difference. We know, and you've seen the data, that somewhere between 5 and 20% of people with chronic hepatitis C will develop these devastating complications. The problem is, early on, we don't know who they are. If we could, that would make this a much more straightforward question. So at that point, when you've got a 20-year or more horizon, it's very hard to build a value-based payment model for specific drugs. It's quite honestly much easier in cancer, where you have intermediate models such as is the tumor shrinking, the quality of life, many of those issues. So there's a lot of work to be done, but we are eager and have sat with pharma and will continue to look for the ways to explore this. One final point, and that is that as you move to models where you ask physicians and hospitals to be on global budgets, and you heard this earlier with Mount Sinai, all of a sudden now the provider systems are looking much more in much greater depth at the overall cost and the overall value. And so this is a debate that will obviously expand even beyond the insurance companies today.
Great. Like all great discussions, we probably raised more contentious questions as well as points of agreement. So with our time being up, I'm going to ask, since we have a 10-minute break, if people do want to, if the speakers will indulge, if there are some questions from the audience, to go ahead and take them during the break so that we can end on time. Join me in thanking our panel.